allow you to see the whole slide and not miss anything from the presentation. And then just lastly, for the housekeeping, as Carlos has already mentioned, there will be a feedback form at the end, which Carlos will post as a link in the chat function at the end, and which we'd greatly appreciate if you could either copy and paste that site to go to the feedback form, or click on the link if it allows you. And then we'd greatly appreciate your feedback just to know how we can keep developing the webinar series and improving it week on week. It's going to be a difficult one to top today, but we'll do our best from your feedback. So we greatly appreciate that after the end of the talk. I think that's it for the housekeeping. We'll give everyone a minute or two to join, and then we'll get started.
Anma says, good evening, good evening. And Pedro is there from Valencia. Some of the people are regulars, you know, which is good. It's good. Good. Make it a habit. My friend Luis is in Portsmouth now as well. Say hello to him. I think he's joining us as well. Hey, Luis is there. Luis, good evening. Welcome. Right. So it's 2033. So Dimitri, just go ahead. Yeah.
Yes, thank you, Carlos. So good evening, everyone. It's our great honor this evening to be joined by Professor Alan Gilbert to be speaking to us on the early management of obstetric brachial palsy, brachial plexus palsy. He is an internationally renowned expert and world leader in brachial plexus surgery in both adults and children. During his amazing career to date, he has been the head of clinic at the Faculty of Medicine in Paris and is associate professor at the Faculty of Medicine, Saint-Antoine. He also served as the president of the French Society for Surgery of the Hand, as well as the president of the European Federation of Societies for Surgery of the Hand. He continues to operate and travel around the world and both performs and teaches brachial plexus surgeries, particularly on children. And he's speaking us tonight on the early management of obstetric brachial plexus palsy. We're extremely grateful for your time in teaching today, Professor Gilbert, and we look forward to learning from you. Thank you very much for your presentation and webinar this evening.
Thank you. Professor, if you click share screen. Excellent, that's brilliant. That shows nicely.
Well, good evening, everybody, and good evening, and sometime probably for some of you, good morning. I want to thank our British colleagues who are so dynamic in organizing the teaching, as it has always been a tradition in the society. The subject tonight is the early management of obstetrical brachial plexus. Of course, many of you will never see an obstetrical paralysis in your life because this is not so common. Remember that the percentage of obstetrical paralysis is around 1.5 per mil birth. And if you make the calculation in your neighborhood hospital, many will never have to see one. But when you see one, it's a real disaster. It's a disaster because this child is born with a handicap, and we will try, of course, to make him better, but it's very difficult to reach normality. And so we are going to see what is our aim to try to improve these children. First, when you see one of these children, and usually they are sent by the obstetric department or sometimes pediatrics, you see that many of them are looking. Just by looking, you can see it's an upper palsy because the arm is internal rotation, there is no elbow flexion, but there is still good finger flexion. And this is what we would call the upper palsy. Sometimes, unfortunately, it's a complete palsy. That means the whole arm is paralyzed and even the hand is paralyzed. And associated with this flail arm, very often you will find the Horner syndrome. This Horner syndrome has been described as a pathognomonic part of the paralysis, but in fact, it's not so something which is so common. Let's see, for instance, this child who has no, of course, but look at this child, for instance, very severe Horner syndrome. This baby, she's now 4 months old, and you see, with this very severe Horner syndrome, she should have a completely paralyzed arm, or at least hand, but she has a normal hand. So it is not a pathognomonic sign, and it can happen that you have this Horner syndrome without paralysis. On the other side, this patient has a completely paralyzed hand, but no Horner syndrome. So it is important, but it is not pathognomonic. Another question is, does congenital brachial plexus exist? It seems a very theoretical thing, but it's not, because you will be implied sometimes, maybe in your life, in a law suit where the obstetrician will say that the patient had a congenital brachial plexus. And you will say no, because we know that brachial plexus is traumatic. But in fact, what makes it complex is that there are very few, but there are cases of congenital absence of the brachial plexus. See this patient who had a complete paralysis, but lacking the thumb, and at operation, there was absence of brachial plexus. And this is severe congenital brachial plexus. This is not the fault of the obstetrician, of course, but very rare. You see, I saw only 3 cases out of 6,000. Now, differential diagnosis is important because when the child is paralyzed, he can be paralyzed by something else. He can be paralyzed by a clavicular fracture, which is quite common. It is common because the obstetrician often breaks the clavicle in order to help the birth. Or it can be a humeral fracture, which looks very bad, but in fact, after 3 weeks, this will heal completely. So when you have suspicion, of course, you should make an X-ray, and after a few weeks, the functionality of the arm should be normal. More rare are metaphyseal fractures like this, and we are closer to the shoulder, and of course, this can mimic very well a paralysis. And even worse, the upper humeral epiphysiolysis. This is extremely rare. And I show you, I've seen only 2 cases in my life, but of course, this is, if you remember, or for those who have read it, this was described very well by Zancoli on his study of obstetrical paralysis. And then shoulder dislocation. Shoulder dislocation is extremely rare. Neonatal dislocation is very rare. I have seen in 40 years, you see 4 cases only. And the only thing you need to know, besides, of course, making the diagnosis, is that it cannot be treated by orthopedic means. That means you have to operate. These patients, you cannot put back the shoulder just by external maneuvers. Now, when you see this child, you have to study and know what is paralyzed and what is the extent of the paralysis. And it's not easy because in small babies, they have almost no active voluntary movements. they have usually reactive movements. So what we try to study is functions and not muscles. And in the upper part, we need to study either it can be abduction, it can be external rotation, it can be flexion of the elbow. But the only one which is very precise is flexion of the elbow, because it's only one group of muscle, two muscles, and it's quite easy to study because it's a pure movement. Of course, also you can study wrist and hand. The wrist extension and finger function are important. Now, why do we study biceps? Because it's pure upper roots and because it can be studied individually. When I say that, I say biceps and brachialis because they usually go together. So how do we study the biceps? And that's not easy. That means you have to do a very precise examination. See, the abduction of the arm, you must hold the biceps with your fingers and try to make active movements. And if there is a movement, you must feel contraction of the biceps. If you don't feel the biceps, you have to be careful because it can be obtained with brachioradialis. And this is completely different. Now, another difficulty in examination is wrist extension because it is important, especially to follow the evolution, but not to determine the indication, but the technique. Up. I don't know what happened. Yeah. Not to determine the indication, but the technique, and we will see why it is so important. Now, hand function is very important, of course, and because this is the most important function in the upper extremity. If you have, and we will see that, if you have recovered a good shoulder, a good elbow, but no hand, you have function equal to 0. So that means that lack of function in the hand leads automatically to surgery. That's why it's so important to evaluate the extent of the paralysis to decide of an exploration for the timing and also to prepare the child and the family of the different technical path that we will need to use. For instance, clavicular osteotomy or contralateral C7 or harvesting of graft. You must explain everything to the family before the operation. But it's not easy because often, the hand is not totally flail. If there is a partial hand impairment, that means that you have to precisely explore the lower roots. And of course, there is a problem of C7. This is a slide from Borrero, and look at this patient. This patient had no wrist extension at 3.5 months. And of course, you would say lack of C7, but he explored it and he found a normal C7. This patient, the other patient, has excellent wrist extension and finger extensors. And at exploration, it's an avulsion of C7. So forget in your mind the idea that C7 means wrist extension. So, of course, you realize that the examination in the child is not easy, and we examine only functions. And that's why there are few scales, and this one is the most famous scale, and it was published in 1972 by Mallet, and it's a famous shoulder scale, except that you cannot use it for babies because they cannot do voluntary movements like this. So it's only for older children. There was a study that we did in 1977 about the spontaneous recovery according to the age of biceps recovery. And this was the fundamental study for me to decide my indications. And what we found is that if the biceps had recovered at 1 month, the arm would be completely normal. Between 1 month and 3 months, we would usually, the average would be grade 4, which means a good result that does not need operation. And if it was more than 3 months, if over 3 months there was no biceps recovery, usually it was only grade 3, which I find insufficient and will need a nerve repair. In complete paralysis, the problem is different, because if you do not do anything, then you will very often have a partial proximal recovery, because the upper roots are only ruptured or have little injury, but the lower roots will not recover because there is an avulsion. So after 5-6 months, if you wait too much, the family you will not understand very well, because they have a partial recovery and you will have to cut everything in order to recover the lower roots. So it is not easy to have the families accept to lose to do the operation. Now, there are still some controversies. One is, should the obstetrical brachial plexus be operated? I don't think it's any more a controversy. And the other one is, when should the decision be taken? Should it be operated? Of course. The difficulty when you look at the literature is the assessment of the pre-op and the assessment of the result, because everybody has different scales, and what we call a good result is not the same for everybody. It's not the same for a neurologist. It's not the same for a physiotherapist. So it's very difficult to really assess what is a good result and what is a poor result. Now, I use, as you have seen, the biceps recovery, but there are other scales like Toronto scale, which was defined by Howard Clark. And of course, the problem I have with this scale is that it doesn't test the biceps, it tests elbow flexion. And as you've seen, elbow flexion has a totally different significance than biceps, because elbow flexion you can have with a complete avulsion of C5, C6. Now, since our study in 1977, there have been several very good studies comparing the original lesion with the end result by Schauberg, Wale, Grossman, and all of them has showed about the same results as ours. And there was a very good paper by Pondag in 2004, where he studied all the publications, and you can see one of his conclusions is that spontaneous recovery is notably worse than it is suggested in most review. And this is the paper. I really encourage you to read it. The conclusion is physicians should exercise caution in predicting excellent recovery shortly after birth. And this is very important, because this is probably the cause of most low suits, because what the patient don't accept, the family don't accept, it's not that there was a problem. Of course, they don't like it, but they don't accept that somebody lied to them and told them, don't worry, this will come back. And this is usually these patients who go to the court. Pondag wrote another article very recently in the Journal of Hand Surgery. I'm not even sure it is published yet, but you will find it. And this is a kind of upgrade of their other article, and it's in the Journal of Hand Surgery. And they gave their idea is that the absence of anti-gravity elbow flexion using the biceps remains the main indicator. Now, when should it be done? That's a big discussion. And in fact, we are not always very honest with that. Why is that? Because, for instance, I write everywhere, we should operate at 3 months. But one is you sometimes see patients later. Other thing is, you all know that it's sometimes very difficult if you see a patient at 3 months to put him on the list for the next week. So to be honest, you may have to wait sometimes 2, 3, 4 weeks. So this is a theoretical number. You know, some people say it would be 3 months. That's most people. But some people say it would be 6 months, 9 months, and others depend on an assessment scale. The reality is that, is there a difference if you operate at 3 or 6 months? In the results, probably not. And when I compare the results of my patients operated at 3 months and those operated at 5 or 6 months, there's really no difference. But the problem is whether the decision will be more precise at 3 or 6 months. And this has not been proven. So that means that even though you may have to operate at 6 months and it doesn't make any difference, but if you start saying it should be operated at 6 months, you may sometimes do some errors. Why? Because also the psychological argument, because you start having some signs of recovery, and you know that it will be partial, that it will be limited, but in fact the family sees hope, and then they will have somebody, a physiotherapist or somebody saying, well, wait, because he's getting better. And then you end up with a patient who disappears, and that you will see him 2 or 3 years later with very severe sequelae. So that's why it's more difficult to operate later than early. So the choice we have is between an early operation with the risk of an excessive indication or late decision, which will induce some refusal. So that's up to you. But in my case, I always try to do an early surgery when it is possible. Now, the indications. Let's go back to what we say. Upper palsy, no biceps at 3 months. But then we will see that there are some precision. Complete palsy, Horner syndrome, no hand function. But I like to wait 3 months. Some people do it at 2 months. And it could be, I'm not saying anything. At 2 months, probably you could have the same good indication, except then we come to another problem, which is anesthesia. And you know that there is if you speak to your pediatric anesthetist, they don't like to operate 2 young babies because it makes a big difference at usually 1 or 2 months difference. I have seen quite a lot of patients, and these are the patients repaired. Now, just aside, not very interesting, of course, more right and left, this is well known in obstetrics, but there are bilateral cases, and these bilateral cases are almost always, if not always, of course, breech presentations. So when you have a patient which is a breech presentation, you know 2 things. 1, it will very often be bilateral, and 2, it will almost always be avulsion injuries on both sides. Should we do EMG? Yeah, it could be useful for more precise diagnosis, but not for prognosis. Do not rely on EMG for prognosis. MRI, for many years, I felt that it was not necessary, and it was maybe complex. And now I consider that it is very important now. Myelogram, I used to do a lot. We have stopped, of course, now because a lot of false positives. And the myelogram, myeloscan was precise and has been replaced by MRI, which not always very good, but it's becoming now very good if you have a good radiologist. Now, let me show you something which led me to change my mind. I have a series of 42 patients where I had 4 complete failures. And these complete failures, I was able to revise the patients and remove the allograft and study it and do nerve transfers. And in the 4 complete failures, 1 of them was a disruption of the distal suture, and 3 were errors on proximal roots. And you can see I did secondarily in these patients MRI, which I'd not done before. And on the MRI, I could see that it was a mistake that I did, and I grafted on roots which were not good. And remember, I have done this surgery for almost 50 years, and I've seen thousands of patients. So that means you can never be sure how good is a root just by looking at it. Now, intraoperative decisions, of course, are difficult. And now, when you have this upper palsy and a completely flail shoulder and elbow, that means avulsion injury of the upper roots. Then it is the indication of nerve transfers, biceps to musculocutaneous, median nerve or ulnar nerve to the biceps and brachialis. Double fascicular transfer like this. When possible, that means for avulsion injury, you will do a double nerve transfer. We will, of course, do also suprascapular nerve transfer, and if possible, the medial triceps to axillary. Not always, because we are not sure always that, that we have a good triceps in these cases. This is a patient. And you see immediately one of the problems, of course. This patient has an excellent movement, but as you can see, she has a shortening of one arm. Now, why should we do a double transfer? This is very simple. If you have a neuroma, that means if it's not an avulsion injury, you have a very good chance of spontaneous recovery of at least one of the muscles. So if you do only a single transfer, you have a double possibility, spontaneous recovery and the nerve transfer. If both roots have avulsed, there is no way you can have spontaneous recovery. Then we should have a double transfer, which can give you a better possibility. Second discussion is, should deltoid reconstruction be systematic? I say yes, for the same reasons. If you have a neuroma, there is a good chance of recovery of the deltoid, at least of part of the deltoid. But otherwise, it is not enough to have a nerve transfer, because if you do the nerve transfer, it will work very well. But then when the child be 9, 10 years old, there will be a loss of adduction because it becomes too heavy just for the external rotator. Now, if there is a rupture with no wrist extension, and that's where we come with a wrist, no wrist extension, I will do grafts from the upper roots. And I feel it is better than nerve transfers because of the problem of wrist extension. And I do not want to take the risk of doing wrist extension with distal nerve transfers. Then I will do grafts where I have excellent results. This is with grafts. Again, you see a little shortening of the arm. Why do you want to keep using graft? Is because it's a problem of the wrist extension. We have seen some beautiful results, but there is a risk of making secondary tendon transfer more difficult. And then we need more than just a few cases to prove the reliability of the procedure. And all we have seen in publications are very small series. Now, if we have an upper root rupture with wrist extension, the situation is different. Then it's a good indication for a triple nerve transfer. Single biceps and external-rotators and maybe deltoid. And then it can wait 1-2 months. That's where, when you see this, you are not in a hurry to do it next week. So in conclusion, for upper palsy, isolated neurotization give good result. When a graft is good, the result is close to perfect. And association of grafts and neurotization decrease the result. Now, for instance, these are patients. These are 100 children operated with nerve transfers to suprascapular. You see upper and complete lesion. And we can see two things. We can see that in these cases, the upper palsy patients have much better result than complete palsies. That means that using nerve transfers in complete palsies is probably not as good. Now let's talk about complete palsies. Always, of course, nerve surgery. And we use transfers intraplexal and extraplexal as an association. When we have 3 upper roots, we can repair everything with a graft. Now, if we have only 2 roots left, it's a little complex. Either we can try to repair everything, and or we repair only the upper and lower trunk, or we do an association of grafts and nerve transfers. But this is where the quality of the roots will lead the decision, because if you have only 2 roots and you're going to reconstruct a great part of the plexus, and you're not sure these roots are good, then we don't know. We may have a complete failure. And remember that a failure means not only a bad result, but means also that you've lost most of the possibilities of another operation because you've used all the grafts of the patients. And if you have only 1 root left, there is very few cases where one root is good enough. And usually when you have 4 avulsions, the first root is not so good. So this may be one of the good indications of contralateral C7 using in the same time nerve transfers for the shoulder. And that is another question. Is there an indication for primary contralateral C7? Probably if there are 4 or 5 roots avulsed. This is a patient here, 5 months, and only 1 root, and using allografts. This is the technique by Wang, that Shufeng Wang has published a very large experience on the contralateral C7 using a retropharyngeal route behind the esophagus, and but this is good, very good in adults, but in children it cannot be used. Well, it can be used, but it is no use, because even if you use the retroesophageal route, you are not able to do a direct suture. So you need a graft anyway, so there is no need to take a risk by using this approach. This is a patient who has, you see, he has been left with proximal recovery, and in this case, the only way to recover the hand will be a C7. And I use, for C7, I use systematically allografts because you need a long graft, and usually you're not able to have enough graft if you're doing other things. And the other thing is it's you may lose your sutures behind in the neck. I have operated 42 allografts. And, you see, they have been used in different indications. In fact, even in C5, C6, and C7 contralateral. And this is a patient with a complete brachial plexus here. So he's beginning to have a result. Another patient, complete palsy at 18 months. And here she is. This is after 1 year. See, nothing. And after 2 years after the contralateral C7. You see that it's not the solution for everything, because most of these patients have lack of wrist extension and they need a transfer. Another one at 11 months. And here we are after 1 year. So what is important is that we have seen the result depend largely on the quality of the donor root. Of course, we know it, except that what I felt that it was the allograft is even less tolerant than an autograft. That's why I would keep the allograft essentially for the contralateral C7, where they are extremely useful and they give even better results than the grafts. Now, how late can we repair the plexus? You see, we know that for grafts, we don't get good results after 12, 18 months, but nerve transfers are possible. This is a patient operated 9 years after the injury, a graft to the biceps. And you see that this patient got recovery of the biceps after 9 years. And we presented with Piero Raimondi our cases at the NARACAS meeting, and on 93 delayed nerve transfers. And these are the late transfers for obstetrical paralysis, you see that we found that a large majority of them got more than M3. And even spinal accessory to suprascapular are not as good, but still a majority of them will get a good result. So that means that biceps reconstruction is still possible for delayed cases, and suprascapular nerve reconstruction can be good. It's about 50% of cases. And when we look at the timing, to get an excellent result, we see that if we do the nerve transfer between 12 and 18 months, we get almost all the cases get excellent result. But after 18, 24 months, then we have 50-50. But again, after 24 months, we get some very good results, even after 24 months. And I have a patient who had a nerve transfer after 7 years, who had a good result. Now, let's see all this we have seen. You've seen this management, and let's see the results. C5, C6. These are the classical results with grafts. This patient, you see, beautiful, excellent result. Only problem, of course, shortening of the arm, and we're not able neither to understand it or to modify it. And when we look at the results at 2 years and 4 years, we find that 85% of these patients will have an excellent result. But that means the results, including the nerve repair, and after 2 years, that's why in blue, the 2 years, after 2 years, we include the tendon transfers. So this is the treatment of the shoulder. Now, what was very interesting was that maybe 15 years ago, I looked at the breach, the avulsion injuries, compared with the ruptures of C5, C6. And at that time, there was no nerve transfer. So look at that, it was terrible. We got 91% of excellent results and only 11% in avulsion injuries. So these patients were almost abandoned. Now, when we started to do the nerve transfers, look at the shoulder score, comparing these patients who had only transfers to those with grafts, and the other ones are complete palsy, but you see that with nerve transfers, these patients had even slightly better result, or at least as good result as grafts. It's not statistically significant, the difference between the two, but they have at least as good. So that means that the big advantage of the nerve transfer has been to treat these nerve avulsions. So we know it's a very good option, and especially in these cases with upper palsy. But when we look to patients with complete palsy, it's not as good. And you see that we have only 1/3 of the patients which will get excellent results. And these are the final results. You see that altogether, we have almost 75% of the patients which will reach grade 4. Now, 5, 6, and 7, of course, they're not so good. Remember, it was 85% for the C5, C6. Why is that? It's because usually there is an avulsion injury included, and the lesions are more severe. But what we do is we have sometimes, of course, excellent result, like in this case. But you see, look at that shortening of this patient here. 5, 6, 7. Incomplete paralysis. This was a paper published in the Clinical Orthopedics quite a long time ago. And you see that very few of these patients are breech presentations, and most of them are heavy babies. And they were mostly operated at 3-4 months, but you see that some of them were operated much later. And when we look at the shoulder, it was very interesting that we get only, at 5 years, only a limited number of those who have reached a good shoulder. And this is usually what you get in this patient who had a complete palsy. Elbow is different. When we look at elbow, we can find that, in fact, these patients will reach, almost all of them have a good result on elbow even after 8 years. But even at 2 years, they have good and good results. You see that when we put 4 and 5 together, 80% of these patients will have a good result on elbow. So elbow is not a problem. It is very rare that we have to do secondary surgery on the elbow. For the hand, it's different. And this is the grading that Raimondi and myself have published. And this is the grades, 0, 1, 2, still no good. You see, even though you have some movements of the thumb, this is a very poor hand. Grade 3 looks quite good, but usually there is lack of extension of the fingers, and it's not excellent. And only at 4 or 5 do you get good results. And when we look at that, we found that at 2 years, you can see that only 35% of the patients have a usable hand. And at 8 years, it becomes 76%. That means that you have to wait a long time before you see the result on the hand, but you get a reasonable result on the hand. So my conclusion for everything is that, of course, surgical treatment is superior, especially in severe obstetrical lesion. You need a very good clinical initial assessment. It's very important. And the nerve transfers are useful, but cannot be the unique treatment. Beware of the people who tell you that you can apply nerve transfers to everywhere. And delayed nerve transfer can give very good results. So do not forget them. If you see a patient who's 1.5 years or 2 years, there's still a place for nerve surgery. And in severe multiple avulsions now, I would like to use the Contralateral C7 when possible. And of course, using allografts. Thank you.
Thank you very much, Professor Gilbert. That was an amazing talk. It's great to see your algorithms for management and your experience over so many years. It's fascinating for us to see, especially for these cases that we don't see very often, if at all, like you say. There's lots of questions coming in, so we'll get started with a few of them, if that's okay. Our first question is actually from Mr. Dominic Power, who's giving the talk on adult brachial plexus injury next week. He asks, are the results of late nerve transfer only useful in the setting of a neuroma in continuity due to some preservation of some subclinical nerve muscle integrity?
Well, he's right. I didn't go into details, but to do a late nerve transfer, you need to have a living muscle. And to get a living muscle, you have to prove it. And we do to all our patients have a study with EMG looking for fibrillations. But fibrillations means normally that it is at least a part of the muscle is alive, but we are not sure 100%. And this is more often, of course, in children, in babies, than in adults, where it is rare after many years to have still a living muscle.
Lovely, thank you. We've been asked by a few people with regards to your choice between allograft and autograft, and whether this depends on the specific length of the graft that you require, and if you have a specific cutoff for this.
You mean for contralateral C7?
Yes.
Yeah, I have used it for everything, and I'm now restricting to contralateral. I find that if you can, for a C5, C6, if you can use autograft, I usually have better results than allografts. But in contralateral C7, I have better results with the allografts. There are several reasons, but one of them is that, you know, that people using allograft for distal nerves, they have very good results in large nerves. But I think the idea is that if you have a good normal nerve that goes into the allograft, then you will have a very good result. And if you use the contralateral excellent C7, then you will have a good result. The second thing is that you need the graft for something else, usually.
That's true. Lovely, thank you. And another question from an anonymous attendee who asks, are your transfers end to side or end to end? And what is your theory of how end to side transfers work?
I have published a paper maybe 10 years, 12 years ago with Bondak on nerve transfer, on end to side transfers. What we found is that in our patients, end to side would give sometimes beautiful results and sometimes nothing, which means it's not a predictable technique. And I would use it only in cases where there is no other solution. For instance, if you have an isolated avulsion of one root and nothing to use it, for instance, a C7 that there is no real good nerve transfer or anything, then I would put it on C8, for instance, or on C6. That could be very useful. But otherwise, I wouldn't use it as a systematic technique.
Okay, thank you. We've got an interesting question from Andrew Lissack, who asks, what's the deficit to the healthy hand if you take a contralateral C7 transfer?
That's an interesting question, because I have, of course, seen in the literature, and I know very well Wang, and he has some very severe complications sometimes. I must say one thing, I have not done very, very large numbers, but I've done about 40 of these cases. And some of these patients in adults, the only deficit they will have, at least after a few months, will be some tingling on the thumb and index. I've never seen a paralysis. And in babies, it is difficult to assess a baby, but in babies, the families say there is absolutely no deficit. So in my cases, there was no complications, but I know that in the literature there are some. And it's probably due also to the way to raise it. You have to absolutely avoid the posterior branch of the C7.
Oh, that's a great technique, yeah, thank you. We've got a few comments in from Miss Deanna Middleton. Thank you for your comments. She's an occupational therapist, I believe, and she asked, what is your preferred age for the best time to perform a wrist extension transfer?
Wrist extension. Wrist extension, I will not do it usually before 3 or 4 years old, because for two reasons. One is sometimes it's a late recovery. There is late recovery, and some of these patients get some recovery. And the second thing is that you need to have good, very good anterior muscles, and you need to wait until they are very good. And also, the other problem is when it's associated wrist extension and finger extension, because wrist extension is easy to recover. Finger extension is not easy at all.
Okay, thank you. And there's a slight follow-up to that from Zahir Fadel, who asks, would you ever perform distal nerve transfers for obstetric brachial plexus injury patients to restore PIN function from supinator, for example? Quite specific.
Well, that's what I discussed. I have done, of course, all these things, and I have had some beautiful success, and some of them were not so good. So I'm a bit reluctant to use these transfers if I have a good tendon transfer. I know very well my tendon transfers, and although they're not perfect, they can be quite good.
They're another option. Lovely. We've got an interesting question from Miriam Parkinson, who asks, in young children and babies, are they also subject to the same neuropathic pain after brachial plexus injury as you see in adults?
This is an argument I have with the people from Toronto, because they published a paper saying that all children have pain after 13 or 14 years and everything, and that's not been my experience. My experience is that it exists, but it is extremely rare, and they say that because I don't ask them, probably, but if the patient does not complain, I try not to induce him into thinking that he has missed something. So this is a discussion. For me, there are very few of these cases, and it happens quite late. It happens, there are two times. One is when they are adolescent, 15, 16 years. Sometimes they have pain, and I'm sure there is a part of psychology in this. And the second part is later, and this is sometimes the beginning of arthritis of the shoulder.
Oh, okay. Thank you. And just a couple more questions now. One question from Facundo Zablaregui, who asks, what other options do you consider for SS recovery? Neurotization, for example.
Sorry?
Any other options for SS recovery?
For what?
Sorry, SS, subscapularis recovery.
For subscapularis, well, the spinal accessory is an excellent, I've shown you, if depends on the indication, but if it's isolated, if it's upper, you get almost 100%. If it's a complete paralysis, it's a little different, but then you don't have any other option.
That's true. And I think our last question for now from Kate Brown, who asks, what is your opinion on clavicular lengthening procedure later on?
What for?
To be honest, I haven't heard either. I'm
sorry, I don't see I've never heard of this operation, but I don't know. Maybe there is an indication, but I don't know. I don't know about this operation.
It'd be interesting.
Maybe she could say why he was doing or she was doing this. Why is that?
Kate Brown, if you have any comments on that, we'd appreciate them. We can ask them in a second. But yeah, I was interested to learn about that as well, so I thought we'd ask. I think on that note, we'll hand back to Carlos to finish the webinar, but we'll see if we get a comment in. I'll let you know, Professor Gilbert. Thank you very much again for an amazing talk.
Thank you all.
Questions. Thank you so much.
Yeah, no, thank you very much. That's a fantastic review of that. And thanks for sharing your experience, because many people talk about this, but I think your experience is unique. But not only that, I don't think it can be repeated, because the way things are now, nobody ever is going to accumulate the experience that
you
have had, and that your generation had. And another thing that always I found amazing about you is is that the few people who've done this in Europe, for example, like Pierre Raimondi, yourself, and Naraka's, you were quite a close group, and you obviously worked together a lot over the years.
Yes.
To develop this, and I think that's made a big difference to how the field has developed. And I think that's a good example for many surgeons that try to work in isolation. That's not as productive as it's been, for example, in this field where things have developed so much, and you've done such an amazing work. And also the way you've recorded things, and you know the numbers and you know the results in a field that's not easy. So thank you very much. As somebody said in the chat, you are a living legend. We are very lucky to have you with us.
I'm still alive, so it's good.
Still alive. That's what they mean, yeah. Which is good news. And I'm delighted that you've done this for us and enlightened all of us. Thank you very much. And if you look at the chat, you'll see many people thanking you for an absolutely great presentation.
And thank you for organizing.
And thanks to Dimitris for chairing us. Always on the ball. Yeah. And thanks to all the audience for participating with us. Have a good evening, everybody. Thank you.
Good evening.
Bye.
Thank you very much, guys. I've put the link for next week on the chat. You'll find it there. Just before you go, see if you can fill in the feedback form for us. Thank you very much, guys. Have a good evening. Tim Hems is there, another expert. Thanks for joining us. Thank you, everybody. So next week is the follow-on from this, which is the adult brachial plexus injury, and Dominic Power, who was today in the audience, will be leading that, and he's got a vast experience, not only of treating them, but of developing a service to treat them. And I'm sure he'll give us some great insights into that. Yeah. So Dimitris, thank you very much. Have a good night. Mike Somerville, Mike, haven't said anything to you tonight. And Takehiko Tagaki is there. Firdaus, good evening. Rahab is there. Adeline, good evening, everybody. Jill, thanks for joining us with this. And Kate as well was there. Some of my colleagues in Derby were there. Yeah. Good to have you there. Right. Have a very good evening, everybody.
Good night.
Night.